Good afternoon, everyone. By the time we get through to our IC, I'll just have one obligation to do, that is to talk about demystifying optics of monofocal lens. And finish this and then we'll start. Well, I have no financial disclosures. We can start with this patient whom we all get in the outpatient, a 65-year-old. Who had a best corrected visual acuity in the, we'll talk about the left eye, of 6/24 and 12. He had a cataract in that eye and we advised him of phacoemulsification with a thickness eye-hands lens. So based on his lens star, we decided to put a 21 diopter lens. His surgery and post-op period was eventful. It was lockdown period. He came 2 months later. And his best corrected visual acuity was uncorrected 6/6 and 6. This is how the eye looked like. But how do we explain it? Is it only because of the higher order aberrations or the eye-hands lens, which is the best predictor for this visual outcome? Well, we do know that there has been a change in our intraocular lenses, right from the spherical monofocals where you had just quantity, to better quality with aspheric monofocals, to then multifocals, and now where you have a range of vision, that is the monofocal plus and the EDOF lenses. These lenses are of different technologies that they are. Let's deal with a few of them. So first was the spherical aberration based optics. Over here, though it's an aspheric lens, the center part of the lens has more spherical aberration. This creates a better depth of focus, but it comes at the cost of a resolution, so you don't get sharp images. The second was the normal aspherical optic design, where patient needed intermediate glasses. Then came the zonal, where you had a central power which was more, and then you had a higher power in the mid periphery. This abrupt change caused dysphotopsias and low modular transfer function. And then the eye-hands, which was the higher order aspheric optics. This has no rings and no zones. It's just that the central 15 microns or the 1 centimeter has an increased curvature of around 15 microns. What this does is it gives a range of vision, and thus you get a better depth of focus than it being just a monofocal IOL. So what is an EDOF actually? What do you mean by EDOF? Well, according to the FDA, it is when you have a good 20/20 vision for distance and a 20 greater than 20 or lesser than 20/32 for intermediate. So it's not based on any technology. And what is the direction for use of eye-hand says? It says that the intermediate vision along with the distance vision was mentioned to be better than 20/32. The DFU also said that the eye-hands uses an aspheric anterior surface that creates a small continuous increase in the central lens power within the 1 millimeter diameter. There are multiple studies which do show that you get better intermediate vision with eye-hands as compared to monofocal lenses and other lenses. So this study was comparing the Technis eye-hands with the Technis monofocal, where they looked at 64 eyes of 32 patients. Each patient had bilateral implantation, so 16 of them had eye-hands, 16 of them had Technis one piece. And then they looked at different parameters. They found that they looked at binocular vision, and they found the distance corrected and uncorrected intermediate visual acuity was better in the Technis eye-hands group as compared to the Technis monofocal. When they plotted the defocus curve, they found that the Technis eye-hands had a larger landing zone as compared to the Technis monofocal. They also found that there were nearly 84% of these patients who were spectacle independent, and there was no significant difference between the two groups in terms of photic phenomenon such as glare and halo. So this was an in vitro study with a 20 diopter lens, where they found there were similar values of energy on the optical bench strength when they correctly focused on the core region both for mesopic and scotopic pupils, which were greater than or equal to 4 millimeters. The authors concluded that the Tecnis Eyehance is more likely to induce a similar level of photic phenomenon, if any, as the Tecnis monofocal lens. So when you look at the modular transfer function area at the 2 millimeters, you'll see that the curve is broader for both the IOLs. This is because this relies on the paraxial rays. However, when you look at the Tecnis Eyehance, you'll see that there is a myopic shift of around 0.4 diopters. This is because it is based on the larger spherical, negative spherical aberration, which gives an increased depth of focus. So, well, will pupil size affect the vision with Eyehance? Well, no. The stimulated visual acuity for both far and intermediate is pupil independent. What about the effect of decentration? Well, even both the lenses were equally tolerated for decentration, as both the Tecnis Eyehance and the Tecnis monofocal were similarly tolerant to decentration. So what do? I generally aim for a minus 0.5. It can be used in all patients where I would use a Tecnis monofocal. It has a landing zone of, astigmatic landing zone of around a 0.75 diopters. It has become more or less my first choice intraocular lens, since I have this same chair time as a monofocal IOL, especially in patients where your contrast sensitivity is reduced, like glaucoma, diabetic retinopathy, or ARMD. We need to be wary in eyes with high negative sphericity, like keratoconus or hyperopic ablation, though there is a slightly larger landing zone. And in patients with higher order aberrations like coma and trefoil, you do get dysphotopsias, but you'll get them with any of the intraocular lenses. The field of vision with progressives for intermediate is compromised due to the hourglass pattern design. And if you do a mini or a micro mono vision, you get less spectacle dependency. Patients can perform daily activities, the intermediate, like playing a piano or walking up and down a stairs, more comfortably with these lenses. So how do you refract these patients? So these patients, you need to refract them just like how you would do to a young phakic myope. You prescribe a maximum plus or minimum minus. This maximizes both distance and intermediate vision. And autorefractors, they use the central part of the pupil to estimate refraction. They would not be able to capture the continuous power progression of the enhanced monofocal. So, well, how does it compare with other intraocular lenses? So, where there were studies comparing it with the Acrisof IQ, and they found both the better intermediate vision with Tecnis Eyehance compared to the Acrisof IQ, while maintaining similar distance visual acuity. They also found that the nighttime contrast was better compared to its other competitors. It is based on the same Tecnis platform with a spherical aberration of around minus 0.27. There is no glistening, and it has a high Abbe number of around 55. It's available in plus 5 to plus 34 diopters. You also have the Eyehance toric, again in the same powers, which from the ICU1 to the ICU800, which corrects around 5.5 diopters. Well, to conclude, intermediate vision is the need of the hour in the current lifestyle, and Tecnis Eyehance is a truly refractive monofocal plus IOL with technology edge in the optic design. The photic phenomenon is similar to that of a standard monofocal. Can be a good choice even for night drivers. It decreases the dependency on glasses, especially for intermediate vision. Well, thank you. So now we'll move on to our IC. Come, sir. So, well, IC is the art and science of communication, where if you have a happy patient, you do have a happy doctor. And I must acknowledge two of these young people who helped me out with making some of these questions and formulating these questions. So what this session mainly is it discusses various scenarios that we get as ophthalmologists in our daily practice, and how are we best going to counsel our patients. Well, Dr. Quresh was supposed to be here, but he's been called to the Rangachari Award, so sir is not here. Well, I'll just tell you what his least known fact is. He's happy, though he's married. Next is Dr. Nirmal Frederick. None of these need any introduction. So, sir is a wellness enthusiast. He's a marathoner and cyclist. He's a financial and career advisor, and he represents patients and doctors in state legal service authorities. Well, Dr. Ramesh, doting father. Varshini is such one of my favorite students I've ever had, and a grandfather. So he plays Ashy in League of Legends, and that has made him ambidextrous. Dhanashri, well, she bakes. Everyone thinks she's very mild, but you have to ask me and Ashna that. Sangeet, I think he'll be coming now. He's also a judge in one of the sessions. He was my flatmate when I did PG, and he's one of my early ophthal and life gurus when I knew nothing about ophthal. I didn't know anything. He was the one who would tell me, ye pad, wo pad, thoda sa to pad, and stuff like that. He said, padta kya hai, aise hi seekh jayega. And then Vijay, a very dear friend, fantastic dancer, singer, and has the huge VIP clientele in Chennai, and his father was a film star. He was the James Bond of Tamil Nadu cinema. Well, this is the most boring. We also have MPS sir, one of my favorites, and MPS sir loves cars. You don't need any introduction. Nobody needs any introduction to MPS sir. I'm sorry I don't have his slide here, but he doesn't need any introduction. So let's start off with the first question, that you have a patient who comes to your outpatient. What do you tell a patient whom you are advising cataract surgery? Professor Nirmal?
Yes. So generally, I corroborate with the symptoms the patient have. If there is, usually if they come with some change of glasses, and if it is not improving, I tell them that glasses may not help. You need to go for surgery. So there are other options like continuing with your glasses, old glasses, or waiting for your visual symptoms to get worsen. Then we also tell the fall rate among the cataract patient and elderly patients, and few other things, why it is not.
What do you tell them? Say if I'm the patient and I have cataract, I have around 6/18 vision, and I come to your OPD. So what are you going to tell me?
Tell you your glasses will not be helpful to you, since you are active practitioner, need a lot of visual things to do. So I would advise cataract surgery to improve your quality of life and visual symptoms.
Okay. Vijay, what do you tell the same thing or something?
Yeah, something. What I tell them is usually just like aging. Cataract is a part of aging, where the patient comes to us with blurred vision. They get really worried and worked up. They are scared that they will be losing vision. We just tell them this whatever they have lost because of the cataract vision blindness is totally reversible. It can be totally reversed. And also we give them all the assurance. We tell them there's nothing to worry, and the best will be done for them. So basically, just like any other part, just like a knee replacement or the wear and tear, this is just lens wear and tear, and it can be made all right.
Ramesh sir?
So, similar to what Dr. Nirmal said, no? If a person comes, I generally, we have all seen the EMR and what the issue is, but we'll ask them, what is the issue? Why have you come to see me? If they say they want a pair of glasses and they have 6/18 in both eyes with best correction, I'll give them the glass prescription and say that with this you will have 50%, half the lines you were able to read. When you want to read the smaller print, please consider surgery, and I will leave it at that till they ask me. If
Okay.
they say that, if they don't say that they want glasses, and they say they want better vision, I will say whenever you want, please have these tests done.
So
and
the
come.
patient says, I've come to your OPD for surgery.
Then about a third of my patients have come there for the surgery.
Then what do you tell them?
They'll clearly say that I have come for cataract surgery. So I will ask them, what do you normally do? Do you watch TV a lot? Do you read a lot? Then after understanding what issues they have, I will tell them, we will post you for surgery. And suppose they say they want to see some program or God's face clearly in the temple, we'll put a lens so that this will be taken care of. Finish all these examinations, come and meet my nurse, and we'll fix a date for you.
So anyone of you want to change what you want? MPSO, you want to take this?
My cataract surgery advice is very different.
Yes. That's why I asked your permission.
My cataract surgery advice, I will say like, you are not able to see outside, I am not able to see inside your eye. So that's the reason. So if he has got a retinal problem and he has come saying that I want cataract surgery, he'll say probably your vision will be about 5% better than what it is now if you undergo only cataract surgery. And if you've got diabetic macular edema, then I'll say like if you undergo cataract surgery, your vision will be worse than what it is now. So you need to have an injection along with the cataract surgery. So my cataract surgery is very different. And it's like if you undergo surgery, your vision will be better than what it is now. And there's a small possibility retina may detach and will be worse than what it is now also.
So do any one of you tell them that you will, there are complications associated with it? So like what I do is I tell my patient, yes, you have a cataract, you need a cataract surgery. So whatever vision is lost because of cataract, once we remove the cataract, that vision will come back. But I also tell them that 99.9% I will place a lens in the first sitting. But if your lens support is weak and if I feel it is risky, I may not place a lens in the first sitting. Then I may need a second surgery. So I tell them this much, I don't go too much into that. You can have a end off, you can have a lens drop or...
We small practitioners never discuss complications unless the patient asks us for that. And if they ask me if there are any complications, I will say yes, there are about 175 complications, and I'll open up a website like AIO or iWiki. These are the common complications. Just have a look at it. Any doubts, you come back to me. I will not tell them ever that.
You will not. Anyone from the audience wants to add on to that? Sir? Only retina.
No, I also tell them one more thing, that like your glasses may not be removed completely, you may still
Yes, sir,
need
we
a
are
smart
coming to
power.
that.
For people who have both diabetic macular edema and a cataract, I tell them that the retina is like the foundation. We'll have to fix it first. The cataract is like the building. So I will do the building part, but first the foundation has to be taken care of. I will send you to my medical retina colleague. They will fix the retina and make it stronger. After they have certified you're fit, we will do the cataract part. So it becomes a two-stage procedure.
So that's the next question the patient will ask, will I get my vision? So then I say, whatever is lost because of cataract, that vision will come back. And like MPS have said, I cannot see inside like you cannot see outside. So I tell them the same thing, that when I cannot see, I cannot tell you. And they say ultrasound you did. I said that is structure. So it's like the wall. It doesn't tell me this wall is good. It could be just brick or it could be just that. So that doesn't tell me. Does anyone want to add anything?
Yeah.
Yes, sir.
What I do, that I tell the patient, since you are aged, say about 60 years or 70 years, you are not going to live, say, for 150 years. This is better to get operated so that you can have a better vision. About glasses and all, usually they don't ask. And at the time of, what is the time of surgery? It's just because we are cataract surgeons, we want to operate. We don't want to postpone the things. So that is what. Just you have to explain that it is your life. It's not a very long life. So it is better to see good vision, have a good vision for the...
Yeah, that's the next question they will ask. You decide when I should do it. And then you say, you'll have to take the call. From my point, I see a cataract. But you have to decide. If
you don't have to waste your time. You just try to think about that. Get your money to me.
And then do it. Yes. Oh yeah, the
Sir,
troublemakers come on the
in
dais
Tamil Nadu,
now.
we are not so blunt, sir. We generally tell them that
What's that?
in Tamil Nadu, we cannot be so blunt. We cannot tell you, prepare your money and come, I'll do the surgery. We generally don't talk like that.
Yes. So the next question is, what do you tell a patient regarding choices of intraocular lenses? Vijay, you can
Yeah,
take this.
usually when a patient comes to me and, when he's ready to undergo cataract surgery, I tell them about monofocal lenses first. I ask them about their lifestyle. Nowadays, I tell them that, a lot of people like multifocals nowadays. Sir, we want to be without glasses. That is, people are very particular about it. Now, the point basically is, first I start out with monofocals. I tell them about, I ask them about their lifestyle, whether they drive in the nights.
So they say you decide which lens is best for me.
Okay. I would,
Then what do you tell
yeah,
them?
I suppose if given to me, I would prefer monofocal lenses. And suppose if the patient, a lot of people are insistent that they want, and then I talk about EDOFs also to them, extended depth of focus lenses. And then when we talk about, when they ask me for a multifocal, I tell them there are a few drawbacks with this, in the sense that I always tell them that multifocal is a means and not the end. Every year there is a new multifocal getting introduced, and you don't know if this is not a 100% lens which is going to, free you from glasses. But at the same time, I also tell them that you may have, glare can be there in the nights, at nights, and driving could be a problem. And they may require spectacles after the surgery. I tell them all this, I make it very clear. I don't give them the moon at all, basically. So I start off with monofocals, EDOFs, and then I speak about multi. And if toric is there, yes, we discuss toric also.
Sir, Ramesh sir?
If they ask me what I'll do for my own eye, I will tell them I'll prefer monofocal monovision. First eye, I will aim for distance. And once you're happy with that, for the second eye, we have two options. We can give you intermediate vision or near, depending on your work pattern. And a large number of them have now shifted over purely to cell phone usage. They are seeing the news, the movies, everything, they come back to cell phone. So we call it distant vision and cell phone vision. That's what I'll do for my patients.
So do you discuss materials? Do
No.
you
No,
discuss
no,
company
no.
lenses, which company?
No. I don't think
You
they...
take the choice of
Yes.
which lens to use. Nirmal sir?
I don't discuss about the brand or the material of the lenses. I tell them that monofocal and trifocal, and if their vision requirement is for computers or like intermediate vision, I recommend the eye-hands lenses or EDOF lenses.
It's on.
Most of the patients who also have some retinal problems such as diabetic retinopathy and who may in future require some retina surgery. So in those patients, maybe it is good to just go with monofocal lenses, because the multifocal lenses, first the patient will not have a much advantage of the multifocal lens, and second thing, it is difficult for the surgeon to do surgery through this multifocal lens. It causes a bit of a problem. So those patients may be better to avoid multifocals.
MPS sir, you have anything to add on this?
No, I leave this to the
Anterior segment.
anterior segment surgeon.
So
I don't
anyone
want to
from
get
the audience wants to say something on this, sir?
So do you also feel that your surgery becomes more difficult through the multifocal and the bifocal and the trifocal lenses? Do you find a difference between the various trifocal lenses and the bifocal lenses?
Used to be with the lander system, but now with the wide angle system, I don't find too much of difficulty.
Okay.
And I don't use a contact lens for peeling the internal limiting membrane or the macular surgery. I use the same wide angle system, so I don't have
You're able to manage
not
whatever
a
lens is
great
there.
difficulty. Yeah, whatever manage.
Thanks, MPS.
So now the patient says that there is a multifocal, I don't want to wear glasses. So then you just tell them about the glare, or do you also tell them that I'm going to make you spectacle independent? You tell them that, no, I'm going to put the lens in, but you may still need
You
a
may still require glasses.
small
Yeah,
power
small
gla-
power may be there.
power glasses. So well, patients with small pupils, retina people never have problems with small pupils. So Ramesh sir,
I prefer to use iris
what do you
hooks.
tell them? What do you tell the patient?
My patients I feel they can't understand these details. It'll make them feel very stressed. So my notes will be that a surgical plan will be to use the hooks.
Okay, but
So,
you don't.
But no, I will never discuss.
But the
these
charge
issues.
becomes different. So then, how
No,
do you?
No, I'll absorb the cost.
You absorb the cost. Nirmal sir.
Lucky patient. No, I tell them that there is a issue because of his additional problems. So the pupil not getting dilated. By the time they come to us, they will know that there is a
Pupils
time
don't
delay
dilate.
and pupil, they would have been counseled. So tell them two things, we will use a ring or a hook, and that would incur cost. We'd also lose a viscoelastic device that needs to protect the cornea and iris. So we tell them straightforward, the additional cost would be there if we use them. So that, and we don't collect it upfront, we collect it only after the surgery.
Because that's generally not covered in the insurance. I
Yeah.
think they have
Yeah,
to
it is.
pay
Yeah.
extra.
So that is a different problem. So,
Yes.
but so let's tackle the small pupil first, then we can tackle the small people outside the
Yeah,
medical
so
industry.
I tell my patients in the outpatient itself that your pupils don't dilate, so we'll need additional hooks or rings to keep them dilated, and that would be an additional cost if we use them. So, but now the patient is also on an alpha blocker. You're worried about floppy iris.
Floppy.
Then, Ramesh sir?
All tamsulosin patients, I was using iris hooks, irrespective of how large the pupil was till last year. Then 6 months back, I saw one of the articles saying that if you have 7 or more millimeters of dilatation with tamsulosin, you can manage. So nowadays, with very well dilated pupils, and some of them really can dilate very well, like 8 millimeters, I will not use hooks. But 6 millimeters and less, even including 6 millimeters, I will use a hook before
Do
I
you
start.
tell the patient anything different?
No.
No.
But nurse will ask them. Before surgery, she will ask them again on the day of surgery, before shifting them, they have a few questions to ask, a checklist. So they'll ask them about any tablets for prostate problems. Yeah.
So most patients who are on tamsulosin know that you have issues with cataract surgery. They will generally come to your OPD and say, I'm on this. So there's no need to stop it. You tell them, yeah, there can be risks. If your pupils don't dilate, I will use a ring to support it. And yeah, that is decided as soon as you put the first wave of fluid inside, you see any bit of billowing or flutter, you go ahead on it. If they are on anticoagulants, do you tell them anything different?
Yes, if they are on anticoagulants, I will tell them that you need to have clearance from a physician. And some of them will say they have to continue the anticoagulants, in which case becomes topical clear corneal. And in some of them, they will say that you can put them on heparin for 2 days, stop it on the day of surgery, and then continue with the previous tablet. So whatever the physician says, I'll follow.
For
I
even
don't
your
make a call.
cataracts, you tell them to stop. For the
I will
cataract?
No, for the cataract surgery, I'll get physician's clearance.
Huh.
Whatever the physician advises, I will do.
That's what you do.
So my physician is used to.
So we don't stop anticoagulants. We tell them to continue. And we tell them you'll get a maximum, you'll get a red eye.
All anticoagulants?
All.
Okay.
And they say, my cardiologist told us to stop. I said, from the eye point, you don't need to stop. You can continue it. You will get a red eye. This is more important now for, glaucoma surgery. Sometimes you can get more bleeding, more scarring. So for there, I would probably say, yes, stop for 3 days. What about the retina people?
So routine retina say depends on the type of surgery. If you have retina detachment, epiretinal membrane
What do you tell
removal,
them also?
no, for those surgeries you need not stop the anticoagulants. But if you have a diabetic retinopathy with a large membrane, highly vascular, then those patients you need to stop because otherwise you will have a lot of
And
bleeding.
you tell them you're on anticoagulants, bleeding may be more, recovery maybe it's little slower. MPS, sir?
Yeah. So it depends on the drug as well.
1.4 or
Our
less.
physician says aspirin no need to stop. If it is a combination, clopidogrel, aspirin
stop.
and multiple, they ask to stop for few days, 5 days. And if it is warfarin, they specifically ask to stop and replace with heparin. So it depends on the type of anticoagulant the patient
Even
is
for
using.
cataract, which you're doing topical?
Any surgery, because that would need, say, in case there is a conversion, you need a peribulbar injection or there is some complication. In that case, I think we'll be in a, so we explain to the patient and we have a physician, in-house physician, so he takes the call based on the risk assessment.
MPS, sir?
Aspirin we don't stop for vitreoretinal surgery. Clopidogrel and other newer anticoagulants, we do stop it for 3 days prior to the surgery. One is the bleeding inside the vitreous cavity, another one is the retrobulbar hemorrhage, which can also happen. And patients who have nephropathy and on heparin with dialysis, heparin-free dialysis for at least 2 to 3 sessions.
Okay. So, okay.
Can you just
If
use
they are
the
on,
mic, please,
yes, sir.
Vatsal? This is a very, very important point.
If patient is on warfarin, it's important to do INR before surgery also. You know, sometimes what happens is patient has done a day earlier, and before surgery the INR may be different. So it's better to do before surgery.
On the day of surgery.
Yeah.
So the
Next,
half-life,
sorry.
so the half-life can vary from patient to patient, especially if they have issues with the kidney or with the liver. So we have to check the INR
INR before that. So, well, now we'll go on back to cataract. Now, patient asks you, will you be using robotic or laser surgery? Now, what do you tell the patient?
Yeah, there's a lot of talk about this robotic surgery now. We have billboards everywhere saying robotic surgery. So a lot of patients do ask me about this femtosecond cataract surgery. Is it good? Is it better than? The general perception patient gets is that this robotic surgery or femtosurgery is better than the normal conventional cataract surgery. They have a psychological thinking. I tell my patients, no, there is no advantage of a robotic surgery over normal cataract surgery. It's been very well publicized. Yes, we do have a machine. We have a machine which, which does the incision and the rexus and all that. But this is best done manually. I just lay emphasis on this. And I also tell them that this surgery is expensive. Robotic is very expensive. And the same results can be got with a normal cataract surgery also.
So you have an option of flax, but you tell them this. Ramesh sir, you're the last in this.
Yeah, last.
You're giving the final.
Final verdict.
Why I'm leaving Ramesh sir to do this, we had a discussion in one of our groups now, and there was a conclusion. So sir will tell us that.
Okay. No, generally patients are well counseled about the cataract surgery, and if they are asking for robotic or laser surgery, they come after some information. So we can't say that it is not available. We'll tell them that if it is a regular surgery, we'll do it here. If it is a laser-assisted surgery, we need to take you to a different center, and we'll offer you the same. We tell them the cost benefit, and most of them, they don't want to get operated elsewhere. So they say, whatever you do, we'll do it here.
Ramesh sir.
So now this is what I normally tell my patients. So if they ask about robotic surgery, I will not say anything much, but they ask me again specifically, I will tell them I'm not doing robotic surgery. I have a good friend. He does it very well. He's an expert. I'll give you his address. Please go and meet him. And I send them to Uma Eye Clinic.
Okay. So, like when we started, when FACO came, they all started saying, are you going to use laser to remove the cataract? So now we used to tell them, no, we are using ultrasound energy. Now they ask, are you using laser to remove the cataract? Are there no cuts? Are you not going to enter the eye? So yes, sir, what would you say?
No, I have an interesting way of putting this. You know, in Bombay, there is only one corner where robotic surgery is done, and it's marketed in newspaper. So I tell this patient, if you go on Google, even the United States is backward country, Germany is backward country. They do not have robotic cataract surgery. They have robotic ureteric surgery, you know. So only this place is advanced. The question is that our place, people do not say laser surgery. They say they do only laser, no surgery.
No surgery, yes.
So there again I say that you go on Google, it will be laser-assisted cataract surgery, and then I don't talk anything further, because if patient wants to come to you, he will come to you, and who is impressed by the advertisement will go there.
So we have a flax in SN. So when patients ask me, would you be doing laser? I tell them no. We do have a flax, but I don't see any major benefit in doing it in you, and your cost will increase, and it's done in only one of our branches. So I'll have to take you there and do it. As of now, I think we had a discussion recently in one of the groups where it was put in Europe, where they asked the panel.
Yeah, Greece.
Which Vardhaman had discussed, where they said none of the panelists would look at doing flax for their own. So if someone comes and asks me, this is my honest opinion, I tell them I don't see any major advantage. It's technology which is in progress. It may get better, and if it gets better, then yes, and cheaper, then maybe yes, we'll start using
And
it.
also, you need a well-dilated pupil for flax. It's very important.
There are
You
multiple,
cannot,
yeah. So as of now, there are very few indications, maybe a subluxated IOL or something like that, which would help, where it would help. Now, patient comes to saying he has been advised cataract surgery. You examine him, there is minimal or no cataract. What do you tell the patient? Ramesh sir?
So I will tell them that you do have a very small amount of cataract. At this point, if you are comfortable with glasses, you can continue, and when it disturbs your vision, please do come back and meet me. So cataract, the indication for cataract surgery is not the presence of a cataract on slit lamp exam. It is that you have a symptomatic cataract. You have some symptoms because of that.
So I tell them, yeah, you do have some amount of cataract, but if you're able to manage, I would suggest you wait.
Come back after 1 year or 2 years or 3 years or 4
No,
years.
come back in 6 months. Because I tell them I don't know how fast your cataract will progress, so there's no way for me to predict. Come back in 6 months. If it's worsened, we'll see then.
yeah.
Nirmal sir, you want to add anything?
No, I think they're almost the same.
Yeah. Okay, so what do you do when a patient starts bad-mouthing or complaining against another ophthalmologist? MPS sir, this is your first.
I would tell them like the perceptions differ. If it's the same, my diagnosis and the line of management is the same, I will tell them I would have done the same thing like what that other doctor would have done. If in case it's grossly different, or if there is like no cataract and patient has been advised cataract surgery, then I would probably say that like perceptions differ. So if you think you can manage with your existing vision for some more time, you can. So if you think you cannot, or are you having glare at night and some problems like that, then that's probably the reason why the other doctor would
If a
have
patient comes to you and he says that other doctor told me there was a Whitheme, and when you look inside there's an RD, then what do you tell the patient?
More common situation is that like he has done a surgery and then patient got worse. So he had a vision before the surgery, then he did the surgery and then got worse. Like it was a macula on a TRD and then something like that. So I would have said like I would have probably done the same thing, and even in the best of hands, retinal surgery is difficult. So 99.9% of the time surgery goes well, and unfortunately you've gone into that 0.1% of the time. Let's see what best we can do to see if we can recover the vision. But I have to tell you that even if I were to do the surgery, can't say that like you're going to get back your vision. Most of the time
He is complaining about that ophthalmologist.
that's what I
do
would
you
say,
tell
like
him?
I would have done the same thing that other person
Other
would
would
have done.
have
But it was unfortunate that in your case it happened like that. That's what I would have said.
I'll tell them clearly, my patients also get the same complications. My patients also are coming back with the same
Don't
problems.
badmouth a fellow ophthalmologist. That is very important. Dhanashri?
Yeah. I don't encourage the patients to complain about other ophthalmologists, because I tell them that you have no idea what was the situation, nor do I know what was the situation at that time and what happened. So it is best that we don't discuss this, and I don't encourage them.
This is what it is and this is what you need. Vijay, Nirmal sir, you want to add anything?
Same.
I'll just listen to him complete the entire sequence, because basically they want to vent out, right? So listen to them fully and then tell at that point of time, we don't know what was the disease or your condition. So it may be because of your bad day or the disease progression. So most of them, they agree. So, but we never ask them to keep on prolonging that complaint.
Don't take it. Vijay?
Yeah, just give them a patient hearing, as sir said, and listen to them. And after that, tell them that, it's happened and we'll do our best for you. That's all.
Yeah. So don't ever.
One point I would ask is, at this point of time, it's always better to keep the watch on the patient or attendant. They usually try to record or so if they act in
Do
a
you allow
different way.
them to record?
No, we tell them that there is a privacy law in place and hospital policies don't allow recording.
But still, they can record without
They
your
can,
knowledge.
but
they
some
can
can.
record.
They can record.
So anyone wants to add anything? Vignesh
Most
sir?
of the patients, they are, surreptitiously they try
Yes.
recording.
Many times.
So you
Many
need
times
to
they
use
record.
the mic.
We have to presume that they are taping us. We have to assume
We
that.
feel that they're not recording, but hidden they do it quite a bit in spite of the hospital loss.
So the
we
best
can't
thing
prevent
is
it.
don't
It's best
badmouth your
yeah, we
colleagues.
also should see that we cover the other ophthalmology because we are also in the same situation some other time. So it's better to
So I
take
think
care properly.
That's one thing which we learnt in SN, that if it's something which is well done by another ophthalmologist, you praise. Say such a fantastically done surgery. If it wasn't well done, keep quiet. That's what you were taught. That just keep quiet about it. Don't have to mention anything more, but don't encourage listening bad about a fellow colleague. Never. You will be in the same place tomorrow. He is going to go and badmouth you to another colleague. If he's badmouthing someone, he is going to badmouth you too. So don't listen to that. So now we'll go on to again in between. Patient has significant astigmatism. You advise a toric intraocular lens. What do you tell the patient?
Right. So we, when we counsel, we have the paper, the IOL calculation paper. We tell them that they are likely to get a cylindrical power. So there is an option of correcting it, or they can also go in for the regular monofocal lenses. So very often we say that they can be without glasses, particularly multifocal or trifocal patients. We tell them they have to correct the toric part also.
If it's a
And we
monofocal, what do
tell
you
them
tell
the
them?
added cost.
Yeah. So you just tell them that much. Vijay, what would
Yeah, I
you
would
add
tell them that one axis is in the cornea, one axis is steeper than the other axis. So for them to get a clearer vision, it's better they go for a toric lens because vision will be much clearer than a normal monofocal
more
lens.
crystal.
Ah,
So I
crystal
tell them you have more power in an axis. So if you put in a toric intraocular lens, it's closer to the nodal point. So very often someone will ask you what a nodal point is. But if they do, I say if you make the whole eye into one point, it's closest to where we place the lens. So your vision will be a little more crystal. But I also tell them that you have a chance that in the early post-operative period, the lens may move. And in which case, I'll need to take you back to the operation theater to dial it into position, and that's an additional cost. So I don't take your cost ahead. If it happens, we'll need to take you back.
Can be told subtly.
Yeah. Ramesha, you want to add anything?
I have a printout from the IOL calculator because my optometrist will do a refraction. For anybody who has got some amount of cataract, they will do the optical biometry and give a printout.
That's
we don't
free?
charge them.
You don't charge them?
We don't charge them.
Okay.
So when the case sheet comes to me, the printout also will be there. So I will mark that axis and say this amount of cylinder is there, this 0.75 or this one, you can wear as glasses or we can put it into the lens, into the during the surgery. So it will be this particular package. Whichever is comfortable, you please choose. So it's a soft
So
cell and we just...
I also tell them that final decision which lens to place is mine. If I feel your posterior capsule or anterior capsule is not good enough, I may place just a 3-piece or which I may just place a normal lens. That decision is mine. So I take the onus on me. I said I will take the call what I think is best for you. Well, the next question, during surgery your patient develops a posterior capsular rupture without vitreous loss. Do you inform the patient and the attendant? If so, what do you tell them? Ramesh sir?
If I'm placing the lens within the capsular bag with a small PCR or in the sulcus and I do an optic capture and I expect the patient to have normal vision after surgery, I will not tell them. But my discharge summary will clearly note that developed a PCR and so I did a sulcus implant with a 3-piece and I did an optical. So my documentation will be perfect, what I give them will be perfect, but I will not tell them because my patients I feel can't understand the PCR without vitreous loss. They won't understand that. And any watering or any blur, they'll say it is because of this. It's not because of this.
No, I tell them that there is a weak zonule or weak capsule and tell them that lens has been implanted. So just to inform them what is written in the case record. And also most often we use a different type of lens. Instead of in the bag, we might use a 3-piece
You put the lens in the bag, there is a small PCR, no vit loss.
Even otherwise, it's better to tell.
Better to tell.
Why Nirmal? Because the patient's post-op course is going to be the same.
Yeah.
Patient is going to see the same. If anything, they won't need a YAG cap. So why do you want to give additional information to them?
There are certain advantages, but we never know where the patient is going to go.
No, wherever
If
he
it
goes, a small PCR is a known side effect of cataract surgery. Why should we use the word complication? Like, it
don't
can
have to
happen.
say
It's not a
complication,
complication. We say that the posterior capsule is weak or there is a small tear.
So we are
or
afraid
there is
our colleague is
adhesions.
going to say, and so we are going to say it, is it?
No, but you're informing the patient.
Inform.
Even I tell them
Just say
that
support
your
is weak.
support
That's
was a
all.
little
Yeah.
Support weaker, lens, we kept the lens. And sometimes, many of them say that they have these floaters next to it. They have these black floaters.
If you don't lose vitreous, the anti-hyaloid phase is usually intact.
It's intact
The
usually.
floaters won't be there. They'll be quite
Yeah,
okay.
so this is that. Now, so I still tell them, because tomorrow I would rather have them trust me and hear it from me than somebody else.
Yes.
So I tell them that there was a little, your support was a little weak, but we placed a lens, there's nothing to worry. Does anyone agree, disagree? Would you inform? Vatsal sir?
So you'll all inform. Small PCR with in the bag
No.
implant, you'll all inform.
Nikhil, no? Anybody else? Yes, sir? Inform? No. How many inform? Hands up. Inform, okay. Okay.
So those who will not inform,
So when you have a vitreous loss, then when do you tell the patient? Do you tell the patient while you're operating? Do you tell the attendant?
yeah. So if I'm doing vitrectomy, I will definitely tell the patient during surgery. Not in terms of, hey, listen to me, you have a vitreous loss, not like that. I will tell my nurse, please get the vitrectomy ready. There seems a little bit of vitreous there. So we will do an anti-vitrectomy. Then I will tell the patient that part of the gel we removed, you will be fine. So the patient knows it's taken a longer time and some extra thing was done. So I'll explain it to them saying that we have removed part of the jelly and you will be fine. And post-op, I will give detailed anti-vitrectomy done, PCR, and I will ask the son to read about it and to explain to the parents if they have any doubts. So it's up to them to read about it and explain.
I will, I tell them usually that the support is weak again. And
So here your
some
floaters
extra-
will come because most
Yeah.
of us use
Floaters will be
triamcinolone
there, as
that
we know,
you
yeah.
cannot wash off
Yes,
completely.
yes. I will tell the patient.
So yeah. Nirmal sir, yes, if you tell them without vitreous loss, you will tell them with vitreous loss. I tell them both ways. So you have a elderly patient with pseudo-exfoliation. How do you counsel the patient?
Nirmal, please.
We have some pictures as well as the models in front of us. So we draw that there is a weak tissue, so it's likely to have a weak support as well, and also the incidence of glaucoma. So the risk of glaucoma and the weak support, and we might need to use additional medication.
So if you're taking the patient up for surgery, so would you tell them more that your chances of
No, we don't give the percentage or chances. We tell them there is a high incidence of, say, delayed surgery or prolonged surgery, and we might need to give a block because most often it is done under topical. For these patients, we do give a block, or we use additional.
Yeah, I usually tell the patients that, that they have some whitish flakes on the anterior capsule, and the pupil usually doesn't dilate for them. And the dilatation is a basis for cataract surgery, and there's no dilatation. We have to use these additional hooks or pupillary expanders. I also tell them that the lens support, the zonules can be weak.
zonules can be weak.
Can
I
be
do
weak.
that too.
Yeah.
And I also tell them about the glaucoma. That
The
you're
glaucoma part of it.
at
yes.
a higher risk of glaucoma.
Yes.
So you need lifelong pressure checks. Don't ignore it because pseudo-exfoliation glaucomas can be pressures can be very high and more difficult to treat. Well, this patient whom you're taking up for cataract surgery also has phacodonesis. Then what do you do? What do you tell them?
I think the counseling part is almost the similar thing, because even pseudo-exfoliations like to have subluxation and rigid pupils, so non-dilating rigid pupils. So the counseling is almost the same.
Okay.
If they have phacodonesis, I will tell them that we won't be able to put the current generation lenses. We may have to refix the lens, either an AC IOL or an iris or a scleral fixated lens, and then I will tell them the cost. This will be the package which will be suitable for you, and we'll be putting a basic lens only inside your eye.
So, well, you need to place a CTR on the table, unprepared. How do you go about it? What would you tell the patient?
No, zonular dialysis need to place a CTR. All these are, I think it's a spectrum. So our counseling is going to be the same thing. So one on the additional risk factors about zonular dehiscence or PCR or corneal injury. The second part is about the cost. I think most of the patient, once we start telling about the cost, they will listen to us. Right? There is additional risk of high complications, additional need for devices and prolonged time, and also the risk factors. We also get a high risk consent for these patients. Apart from the routine consent, we get a
risk for eye.
High risk for the eye as well as about the surgery.
That, high risk?
We mentioned the high risk like pseudo exfoliation, rigid pupil, and then the non-dilating pupil. And then what would be the risk?
So you have an IOL which is placed in the sulcus. Do you inform the patient?
Yes.
If so, how do you explain?
So it's a different type of lens, not the same that has been counseled. So it was placed to ensure that the lens is holding well. So that is the thing we give.
So any one of you would differ on this? Yes, sir.
I tell the patient first, as you have left the things to me, I decide on the table which type of a lens I am going to use. I have given all the options while counseling, but then my question is already answered during the counseling.
So you have a small dialysis. So you have placed in the sulcus, you placed a 3-piece. So
yes.
Then what do you go tell your patient?
That's what I said, na? Okay, as you have left the
you
decision
did what
to
you
me,
thought was best.
Yeah, I have done the best for you.
Yeah.
That is how it is.
So you didn't put the lens which you wanted to.
Yeah, but the other one is
which
equally
I thought,
good.
Yeah.
And it will be more safe for you.
It's
that is
the
how
same
I explain
material,
it.
but slightly
Yes.
different design. And what
Yeah.
I think is best for you, I have done.
We have done it.
Perfect. So posterior polar cataract. Ramesh sir?
I feel we are unnecessarily afraid of the posterior polar cataract. I don't give them any extra counseling. But I'll just do a different way of doing the surgery with posterior polar cataracts.
Nirmal sir?
Yeah, I think I agree with Adi. There's some amount of fear put in our mind by our senior people. So
No,
hardly 1% or 2% have that pre-existing rent. And now once we see that, we try to do a OCT and see the posterior part. Very often, almost 90% of the time, we don't see any rent.
Anyone on the audience, would you counsel differently?
Just tell them that everything is fine, but you may require some VR support.
Yes, sir.
For posterior polar, I definitely will tell them that since you have a possible defect in the center, the surgery may go a little longer. We may not be able to put the same lens. I will definitely, for posterior polar, I will definitely counsel them that you have a different, and I will also push them for an earlier surgery, because if they have a posterior polar and they wait too long, then you can't do a hydrodelamination and all those sort of things. So I tell them that you are able to see maybe even 6x6 right now, but it's the glare which is a problem for you, and for us, the problem is as the cataract becomes harder, the complication rate will increase.
Yeah. So I do inform them too. I tell them there is a possibility, a little higher risk in you than in others for the support to be a little weak. So I would rather have you do your surgery earlier than later. Yes, sir.
Posterior polar, who is going to operate the patient makes difference in counseling. An anterior surgeon.
Yes, that's why I didn't ask the retina people.
So that makes the difference.
They are happier when the lens falls back.
Bigger space to operate, rather than only anterior.
So you did a posterior polar, you have a cortex or epinucleus in the vitreous. What do you tell the patient?
Please.
Nirmal sir?
Tell them that there is a Okay. So I tell them there is a small opening, rent in the supporting tissue, and a few parts of the lens are there that need to be removed with the surgery. And usually it's done by a retinal surgeon.
So
Need
this
to
doesn't need
refix.
removal, it's just a small.
No, if it is small, we tell them that it will absorb on its own.
So you're just
just come
you tell
for
them
the
that part
frequent.
of it has gone back.
So come for regular checkup, and we give them the date. And if they don't turn up, we keep reminding them.
Maestro, when you get a patient like this with an epinucleus or cortex in the vitreous, what do you, the anterior segment is just sent to you for a second opinion. What do you tell them?
Usually they will say there is an epinucleus, but there will be part like 1/3 of the nucleus.
No, there's
will be
only epinucleus now.
Usually that's what happens. When this one small bit is there, means inside there will be nucleus will be there. So what we tell them is like there's a little bit of the cataract is inside, so that can give rise to complications like eye pressure and actually they usually have complications like when they have the eye pressure going up or uveitis is when they come
won't
up.
refer it.
Correct. Yeah. So this can, in the long run, can cause permanent loss of vision, like because of edema in the central part of the retina. So it's better to remove it. There is a small element of risk involved in this surgery. In about like 0.1, 1 out of 1,000 patients may develop a retinal detachment, which can make it worse than what it is now. But 99.9% of the times it doesn't happen like that. That's what I tell them.
Well, if you have a nucleus drop, first for the anterior before we come to the posterior. So a patient needs another surgery. Now how do you communicate to the patient? Ramesh sir?
This, I heard the best answer from a friend of mine. So what he says is, I removed the front of the cataract, the back of the cataract is close to the nerve. My retina consultant will remove the back of the cataract.
Vijay?
Yeah, I mean, I would just tell them that, we tried our best to remove it, but a small portion is gone inside. So this would require another consultant to remove it, and my friend will do it for you.
Your friend will remove it.
Yeah.
Nirmal sir?
At that time, VR surgeon becomes our very best friend.
Yes.
So can you just tell me what the VR
Dr.
surgeons
Dhanashree is
would
always
like us to tell? Yes.
Yes,
So
that's
what
coming
would you,
next, sir.
What would you like us to tell the patient? Before we send the patient to you, what do you want us to tell the patient?
To tell them the truth.
What is the truth? I tell
No,
them that a part of your
usually
lens
what
has
happens is
fallen behind.
correct. Yeah, but like it depends on very small fragment. Patient will come and say very
this
small.
is a full nucleus drop. And this will generally happen with a VIP, Vice Chancellor, total cataract, come and you don't do anything and thup it falls. You just enter the eye and it goes down.
Complications happen with everyone. It's not our test. Like tell them that we'll do our best to correct it. That's our test. That's all.
Yeah,
Correct it early and be with the patient. Make sure that, you're always there for the patient.
I feel that a patient who has developed such complications, any complication which is requires some further manipulation, I take extra time and make the patient sit and I explain to them fully. Sometimes I explain so much that it is almost like a PG class, but I tell them each and everything about that particular subject so that they are well aware that this can happen, and multiple scenarios I describe so that patient has got no confusion about it. But I think you should spend enough time in counseling these patients because they will further cause problems later on.
Yeah, so it's good I send my patients to you. You can spend more
I think
time.
the
Anybody
most
else?
important thing is to tell the patient that there's a problem, and then you have to tell them what is going to happen next. So we have to tell them we'll be with them till they get better and they start seeing, and that I will fix up the consultation with the VR surgeon because he is not an in-house VR surgeon. So I will tell them I will fix up with him, you please meet him. When he does a surgery, I will be there with you. So I will usually be there if I drop a full nucleus. I'll be there in the VR surgeon's theatre, which is not in my hospital, some other hospital, till the surgery is done. And then they feel comfortable. So it's a whole process. Because it's going to happen 1 in 5,000 or 10,000
But you need to be
surgeries.
truthful to them.
Yeah, this is a very rare incident.
Anybody wants to add anything?
The usual concern they have is the financial part of it. That's usually the.
So for small private practitioners, I see it like this. This is like 1 in 5,000 or 10,000 surgeries. So if it's going to cost 1 lakh, it is 10 rupees for every other 10,000 surgeries who didn't have a complication. So I'll offer to pay for it. So there's no additional expense for the patient. If they are covered by insurance.
So whatever they have charged, you have charged for the phaco, that you keep?
Yes. Okay. And that will be given to the next, whatever the next surgeon wants to charge, I'll be reimbursed by my hospital. So there's no additional burden for the patient. Okay. But those who have insurance, they will claim for insurance. If there's, and my VR surgeon does not charge extra for all this.
Sir, usually if we, in case we take the charges for these patients, they will definitely blame us after that. They think that we have done a mistake, we have wantonly done a mistake. That is
Sorry?
I think that,
we have done a mistake wantedly. That is why he is taking our cost.
that was that cheap you should tell us, Dr. Badrinath.
I've experienced that basically, where, the patient said, I think you have made the mistake.
5 minutes.
So we had to immediately turn around.
So if you don't charge, they'll feel that you made a mistake.
100%, sir. The second surgery is,
Okay,
see, it doesn't happen to everybody. It has happened to your eye. So it's better you charge.
There has been
You're safer than
Thank you, sir.
There has been consumer court judgments where patient is given free treatment. It is, as he said, it has been
Taken as a mistake.
taken as that you have made mistakes, so you are
doctor's
paying
mistake.
for your negligence. So at our place, when patient comes like this, I don't say I will do free. I say I'll collect token charge. Because whenever, even in VR surgery, when I do second surgery, third surgery, I always take them token charge. Because not charging is considered.
Basal,
equivalent
thanks
to-
so much. So I'll change my practice from now on.
No, I think Dr. Badrinath was very clear with this. He said never waive off the charges.
Yeah.
The patient will think that you have done a mistake.
Mistake.
So that's why it has occurred, and that's why you're trying to be little extra,
Extra nice
trying
to
to
me.
cover it up. So he would say you charge them. But what we do is when the phaco happens, we charge minimal. You're not charging for the lens. Sometimes if you have extended it, you convert it into an ECC, so the charges.
You want to do good and it can boomerang. Yeah, something.
Yeah, but
something.
pay. But pay.
Correct.
What if you have a post-op endophthalmitis? How do you inform the patient as the operating surgeon?
Right.
You want me to inform? So you're having a severe reaction in the eye. We're not sure what the reason is. It's confirmed end off or it's just a severe reaction now?
We don't know.
We don't know.
We see a hypopion.
So we see you're having a severe reaction, and to be on the safe side, I'll be giving you an intravitreal injection, and I'll see you 12 hours later.
So you give the intravitreal yourself?
Yeah, I'll give the initial dose myself. So if it gets worse and I lose I can't see the disc on the next visit, I will tell them it looks like an infectious process, and we have to take a sample out, and I'm sending you to my vitreous surgeon. He will do a vitrectomy, and he will take care of you.
Okay. So I'll just run through because we don't have too much time now.
Yeah.
As a VR surgeon, what do you tell the patient? Anushka?
That they have developed an infection which is very, very rare, and then I will generally tell them that the incidence of endophthalmitis is as low as 0.03, but sometimes it can happen and it needs to be tackled at the earliest. So
Yeah. So you tell them we take all our precautions, but in spite of it, there's an infection. Don't take the blame on your head.
Yeah, it's important.
Because you have to tell them that it has happened. We have taken all our
Yeah, please
precautions.
tell the
but in
patient you have
spite
done the
of it,
best for him.
You have had it.
And still
you have
this
a
happened.
young patient with poor prognosis. How do you break the bad news?
Yeah, so first we have to prepare ourselves and our team. So generally what I do is ask the patient to come to another room, consultation room, where there is not much of a disturbance. So along with the attender, we also ask the staff not to disturb. So prepare them well and also get all the data, all the documents in place. And I start explaining with the picture. So this is, for example, a myopic patient with a RD. I'll tell them that there is a separation and that can happen in young patients, and because of the genetic thing, you got it. And we prepare them with some assuring information first. So it can be tackled, retina surgeon will help you. And these are the problems associated with this. Once it has come, anyway.
So you have a patient with, a young patient with retinitis pigmentosa where nothing can be done. So Dr. Badrinath had a very special way of doing it. He would sit down, he would get the patient's attendant to sit with them, pull his chair right at the face level, and then say, I'm sorry, but there's unfortunately nothing more that we can do to improve the vision. If there's something which comes up, we have all your contact details, we will call and tell you. So, some like that. So, yeah, this is important. You have a nucleus drop, endophthalmitis, suprachoroidal hemorrhage. How do you handle yourself? This is not something which is easy to digest. So, Ramesh sir?
I think we have to review what we are doing. If the worldwide PCR rate is 1% and if I have 10% PCR rate, I have to improve myself.
No, this is one patient.
This is
you
one
had.
off.
Yeah, one off. So
You
I'll
have
ask
done your
myself,
best.
I've asked myself whether my current complication rate is great, is much less than the international published rate or not. I'd ask myself that. And if it is not, I have to improve myself. If it is on par or better, then I'll just accept it. A surgeon,
How do you accept it?
A
What do you
surgeon
tell yourself?
needs a heart of a lion. So my family will support me. I need to sleep, have a good night's sleep, do my regular exercise. So we have to take care of ourselves. So how do I handle ourselves? We have to handle the
You have
stress.
to take care of
Yeah,
yourself.
we have to take care of
Stay
ourselves.
calm and meditate.
Okay, there are a few things here. If it is a one-off cases, right, and there's always we do a risk assessment and see that within that risk this is possible. Then we tell the patient that, so this is a very rare complication, it has happened, we'll try how to help you out. But there is a risk of losing vision and the prognosis is quite bad.
How do you handle yourself?
Yeah, myself, okay.
Patient you will tell, but it's so difficult to sleep that night.
Take one Angsit, go off for a, just take few hours off, go for a
Retina
walk.
people, let's hear from them. They have more of these.
So, like Ramesh sir said, you need to analyze and see what went wrong and what, if you have the surgery recorded, you can go over it and see what was the mistake that happened and why it happened. So you can do a kind of a post-mortem to see why it went wrong and what. So next time you can avoid it. But there is no point in blaming yourself unnecessarily. Best is to try and move forward and see how you can improve yourself.
We still have a lot more questions, but I think we are running short of time. If anybody else has any question which you, good counselors.
This photopsia, yeah.
One more question. This is an important one. You have a colleague, a patient come, they've had a beautifully done cataract surgery, and he comes complaining to you. You examine, the eye is very well done. What do you tell the patient?
Right. So I tell them that the surgery has been done very well, and so if there are any issues, we'll examine and do the
You have
relevant
examined, you
investigations.
find nothing, but you just have a complaining patient.
So we don't really hear his complaint. If
No,
it
we
is
get
done
that.
well, we say it is done well.
We get, so very easy. I tell them your surgery is beautifully done. Absolutely nothing wrong in your surgery. They say vision has not come and you have a small power, you wear glasses, you're fine. So they say we can't see well. If it's a multifocal, they'll say we have glare. I said your surgeon would have told you that before.
I would tell your surgery is so good that now I feel I should go and get operated by him.
Wonderful, man.
Super. Just rush through it.
Well, there are a few more
Yeah.
questions, but I think we'll hold them.
short
This is another one, aggressive patient.
Yeah.
How do you handle them?
Samadhana Beda Dandam, I told you. Be nice to the patient.
Yes.
Talk to him well.
Spend
and
time.
Spend time with him. Then, in spite of that, if he is aggressive, show him the stick.
And this was Dr. Ramesh's patient. The patient who knows more than you. He was
A very famous patient because of RD.
yes.
No, seriously.
So what would you do?
Yeah.
Anybody want to?
This patient had a -5. He didn't want to get a dilated fundus exam done.
If he's VP from Citibank, I would say that I want
Singapore.
to... yeah.
Yeah,
He's
Citibank.
connected with bank. I would say I want to open an account, but I don't want to give any details. Will your bank open an account? The answer will be obviously no.
Wonderful, yes.
So I say I have certain protocol to follow.
Yes, sir. What did you do? Ramesh sir, should I show the second slide also?
That day I was busy, so I just sent him off.
Oh, it's not coming. Yeah, so sir sent him away. But this was sir's message. He felt bad. He wished he had spent more time with him. And he had come not for a fundus examination, but I don't know why he had come. I agree with you. Why did he come? So there must have been some reason. But
Maybe wanted to
when
open,
someone
start to
is,
open an account, Vineet.
if you are in a bad mood, sometimes you say, yeah, to hell, why should I spoil my mood with that patient? And I think those are days where you need to calm down and say that, no, he may have come. This was very nice of you to have said that. Sometimes we say, oh, he's troubling me. Good, he's gone.
Yes, yes.
Yes. So I think Dr. Quresh is not there for that.
Ramesh, I have an interesting experience, you know. This is about 20 years back. There was a patient, and that day clinic there were 80 patients. This patient told my receptionist that, look, if doctor is going to take 2 hours to examine me, I'll come some other time. And this man had been to 4 or 5 consultants earlier and had given some simple solution. I was happy and he was coming for follow-up. So I got irritated and told him, if you don't have time, please get lost. I don't have time. But then at the end of the day, I realized I made a blunder. I should have listened to him. So we have a computerized EMR for last 23 years. I called him, he didn't receive the phone. So, you know, as our mind would think that he's irritated, so he's not receiving my phone. So I wrote a simple letter of 2 lines. Dear Mr. So-and-so, I ask for sincere apology. I have my sincere apologies and I cannot give any explanation. It's my mistake. After 5 days, he comes and tells me, Doc, I felt so sorry, you had so many patients and I barged in. So, you know, sometimes such small things take a long way.
So I think we'll keep the rest for the next IC.
Yeah.
Thank you all.
Thank
I
you
hope
very
you
much.
all picked up something from what we all